Hi, and welcome to Beyond ADHD, Coexisting Conditions. My name is Trish, and I will be doing the first part of this webinar. I am going to talk to you about coexisting conditions that frequently happen with ADHD, and then I'm going to hand it over to Dr. Arnold, who will share information about its effect on prognosis and treatment. It's very possible that ADHD is only part of the diagnostic picture, and that in addition to ADHD, your child has a coexisting condition. Complex ADHD is ADHD that co-occurs with one or more conditions, and it can complicate the symptoms of ADHD. 2/3 of children with ADHD have at least one coexisting condition. Treatment of complex ADHD begins with treating the condition that is most prominent and may involve behavior therapy, parent training, or medication. When medication is used, stimulants are the first line of treatment. Non-stimulant medications may be considered when stimulants do not work. If learning disorders coexist with ADHD, academic interventions are needed. The symptoms of ADHD, like constant motion and fidgetiness, interrupting and blurting out, difficulty sitting still, and need for constant reminders, may overshadow these other disorders. But just as untreated ADHD can present challenges in everyday life, other disorders can also cause unnecessary suffering in individuals with ADHD and their families if left untreated. Any disorder can coexist with ADHD, but certain disorders tend to occur more commonly with ADHD. ADHD may coexist with one or more disorders. The most common are learning disorders, disruptive behavior disorders, mood disorders, and anxiety. So first, let's talk about disruptive behavior disorders. Approximately 1/3 to 1/2 of all children with ADHD may have a coexisting oppositional defiant disorder. These children are often disobedient and have outbursts of temper. The rate of children meeting full diagnostic criteria for ODD is similar across all ages. It's more common in boys, in children of divorced parents, and those who have mothers with low educational achievement or low household income. Children with the ADHD combined subtype seem to be more likely to have ODD. In some cases, children with ADHD may eventually develop conduct disorder, which is a more serious pattern of antisocial behaviors. Conduct disorder may occur in 25% of children and 45% of adolescents with ADHD. Conduct disorder is more commonly seen in boys than girls, and it occurs more often as a child gets older. Children with ADHD who also have conduct disorder are twice as likely to have difficulty reading and are at greater risk for social and emotional problems. Non-aggressive conduct problems increase with age, while aggressive symptoms become less common. Given the high co-occurrence of ADHD with disruptive behavior disorders, all children with ADHD symptoms and disruptive behaviors need to be evaluated for the possibility that ODD or conduct disorder may be present in addition to ADHD. So, what are the risks of having ADHD and a disruptive behavior disorder? Children with ADHD and conduct disorder are often at higher risk for contact with the police and the court system than children with ADHD alone. These children frequently lie or steal and tend to disregard the welfare of others. In addition, they risk getting into serious trouble at school or with the police. The risk for legal troubles may be mostly caused by the symptoms of conduct disorder rather than ADHD. Disruptive behavior disorders and untreated ADHD have been found to lead to an increased risk of substance use disorders. In addition, adolescents with disruptive behavior disorders and ADHD are more likely to be aggressive and hostile in their interactions with others and to be arrested. It also has been suggested that the greater impulsivity associated with ADHD may cause greater antisocial behavior and its consequences. So the earlier it's recognized and treatment of both the ADHD and disruptive behaviors in children is done, the better. So if you suspect your child has a disruptive behavior disorder, or your child has been diagnosed with one, you may be wondering, what can I do? Treatment of ADHD and disruptive behavior disorders. All children with symptoms of ADHD and ODD or CD need to be assessed so that both types of problem behaviors can be treated. These children are difficult to live with, and you need to understand that you don't need to deal with it alone. Interventions such as parent training, at home, and behavioral support in the school can make a difference, and you shouldn't hesitate to ask for help. So here are the home interventions that can be effective for your child who has a disruptive behavior disorder. First, parent training is effective for treating oppositional and defiant behaviors. Standardized parent training programs are short-term interventions that teach you specialized strategies including positive attending, ignoring, the effective use of rewards and punishments, token economies, and time out to address clinically significant behavior problems. These training programs may include periodic booster sessions. You can find a therapist who offers parent training by visiting the American Psychological Association Psychologist Locator or the Child and Adolescent Psychiatrist Finder on the American Academy of Child and Adolescent Psychiatry, or ACAP, website. Severe cases of conduct disorder may require multi-systemic therapy, which is an intensive family and community-based treatment that addresses the multiple causes of serious antisocial behavior in youth. This approach is very comprehensive and demanding. The therapist using such an approach must possess access to developmental and clinical expertise. These intervention services are delivered in a variety of settings such as home, school, and peer groups. Academic and school-based problems are included, and some therapists work directly with an entire peer group to influence change. Next, we have parent-child interaction therapy. It's a treatment that teaches parents to strengthen the relationship with their child and to learn behavior management techniques. It's effective in the long term for young children with oppositional defiant disorder and ADHD. 3 to 6 years after treatment, the mothers of children with these disorders reported that the changes in their children's behavior and their own feelings of control had lasted. Mothers' reports of disruptive behavior decreased with time after treatment. Another technique that seems to be promising for children with ADHD and ODD is collaborative problem solving. It's a treatment that teaches difficult children and adolescents how to handle frustration and learn to be more flexible and adaptable. Parents and children learn to brainstorm for possible solutions, negotiate, make decisions, and implement solutions that are acceptable to both. They learn to resolve disagreements with less conflict. Another intervention is family therapy. Often, a child's behavior can have an effect on the whole family. Parents of children with ADHD often report marital difficulties. Mothers may be more depressed, and siblings may also develop behavior problems. Family therapy is critical to helping a family address these issues and cope with the realities of having a child with ADHD and disruptive behaviors. Seeking out a counselor or family therapist in your neighborhood can help the entire family address these issues. So now let's talk about how your child's school can help. In addition to the environment at home, the school can have a significant impact on a child's behavior patterns. Many school systems now have programs in place to provide school-wide positive behavioral supports. The aim of these programs is to foster both successful social behavior and academic gains for all students. These programs consist of, number one, clear, consistent consequences for inappropriate behaviors. Number 2, positive contingencies for appropriate behaviors. And 3, team-based services for those students with more extreme behavioral needs. Children's ADHD symptoms, as well as oppositional symptoms, are significantly lower in one-on-one tutoring sessions than in the classroom. So, getting a tutor may help. Providing appropriate instructional supports in the classroom can also lessen disruptive behavior. These include creating an accepting and supportive classroom climate, promoting social and emotional skills, establishing clear rules and procedures, monitoring child behavior, utilizing rewards effectively, responding to mild problem behaviors consistently, and effectively managing anger or aggressive behavior. Now let's talk about how medication may help. Overall results from several clinical studies indicate that medications used for the treatment of ADHD, stimulants as well as non-stimulants, remain an important component in the treatment of ADHD and coexisting ODD or CD. Children with these disorders treated with these medications were not only more attentive, but less antisocial and aggressive. ADHD medications are often effective treatments for aggressive or antisocial behavior in patients with ADHD and certainly play a role in any treatment program. In addition to using stimulant medications alone, medication combinations to reduce behavioral and conduct symptoms associated with attention deficit hyperactivity disorder appear to be very effective. In several studies, this treatment combination was reported to be well tolerated and unwanted effects were transient. So, in conclusion, to increase the chance for a successful future and to discourage delinquent behaviors in your child with ADHD, diagnosis and intervention are extremely important. You need to provide structure and reinforce appropriate behavior. In addition, a positive behavior management plan to lessen antisocial behavior is important. You should discuss your child's behavioral symptoms with your pediatrician or family practitioner and seek a referral to a mental health professional who can suggest effective parenting strategies if you're having challenges with your child's behavior. In addition, you should contact your child's school counselor or school psychologist to discuss possible interventions to improve behaviors at school. Having the counselor or psychologist support the teacher in handling classroom behaviors often results in significant behavioral changes and decreases the incidence of expulsion. Consistent behavior management at home, school, and elsewhere needs to be enforced. So now let's talk about learning disorders. ADHD is not considered a learning disorder, even though it can make learning challenging. Although ADHD is not considered a learning disorder, research shows that up to 50% of children with ADHD have a coexisting learning disorder, whereas 5% of children without ADHD have a learning disorder. Learning disorders can cause problems with how individuals acquire or use new information, such as reading or calculating. The most common learning disorders are dyslexia and dyscalculia. In addition, 12% of children with ADHD have speech problems compared with 3% without ADHD. So, what can you do if you suspect your child may have a learning disorder? Carefully record all your child's behaviors, difficulties, and symptoms. Use that and information provided by your teacher for accommodations for your child in school and for an accurate diagnosis and treatment plan from your child's healthcare provider. So now let's talk about mood disorders. Children with mood disorders may seem to be in a bad mood often. They may cry daily or be frequently irritable with others for no apparent reason. Mood disorders include depression, mania, and bipolar disorder. Approximately 14% of children with ADHD also have depression, whereas only 1% of children without ADHD have depression. Typically, ADHD occurs first and depression occurs later. Both environmental and genetic factors may contribute. Up to 20% of individuals with ADHD may show symptoms of bipolar disorder. This is a severe condition involving periods of mania, abnormally elevated mood and energy, contrasted by episodes of clinical depression. If left untreated, bipolar disorder can damage relationships and lead to job loss, school problems, and even suicide. If you suspect that your child is suffering from depression, please be sure to speak with your doctor about your concerns. So now let's talk about anxiety. Up to 30% of children and up to 53% of adults with ADHD may also have an anxiety disorder. People with anxiety disorder often worry excessively about several things like school or work, and they may feel edgy, stressed out, tired, and tense, and have trouble getting restful sleep. Again, talk with your doctor about any concerns. There are many strategies and interventions to manage anxiety. Next, we're going to talk about sleep disorders. 1/4 to 1/2 of parents of children with ADHD report that their children suffer from a sleep problem, especially difficulties with falling asleep and staying asleep. Sleep problems can be a symptom of ADHD, may be worse by ADHD, or may make the symptoms of ADHD worse. If sleep is a challenge for your child, talk with your child's doctor. There are many ways to help your child to get a restful sleep. Next, we're going to talk about tics and Tourette syndrome. Less than 10% of those with ADHD have tics or Tourette syndrome, but 60 to 80% of those with Tourette syndrome have ADHD. Tics involve sudden, rapid, recurrent involuntary movements or vocalizations. Tourette syndrome is a much rarer but more severe tic disorder, where patients may make noises such as barking a word or sound and movements such as repetitive flinching or eye blinking on an almost daily basis for years. And finally, we're going to talk about substance abuse. Research suggests that youth with ADHD are at increased risk for very early cigarette use, followed by alcohol and then drug abuse. Cigarette smoking is more common in adolescents with ADHD, and adults with ADHD have elevated rates of smoking and report particular difficulty in quitting. Youth with ADHD are twice as likely to become addicted to nicotine as individuals without ADHD. Research has shown that individuals with ADHD who are treated with stimulants are not more prone to cocaine and stimulant abuse than others. In fact, adolescents who are prescribed stimulant medication for their ADHD are less likely to subsequently use illegal drugs than are kids with ADHD who are not prescribed medication. So now let's talk about diagnosing complex ADHD. As part of the diagnostic process for ADHD, a clinician or a mental health professional must also determine whether any other conditions are affecting an individual and can be responsible for presenting symptoms. Often the symptoms of ADHD may overlap with other disorders. The challenge for the healthcare professional is to figure out whether a symptom belongs to ADHD, to a different disorder, or to both disorders at the same time. For some patients, the overlap of symptoms among the various disorders makes multiple diagnoses necessary. Interviews and questionnaires are often used to obtain information about symptoms from the patient, from the family, and teachers to screen for these other disorders. And finally, let's talk about the treatment of co-occurring conditions. Decisions about what disorder to treat first depends on the impairment that those symptoms are producing in the individual's life. Clinicians work with the child and family members to establish an individually tailored, comprehensive treatment plan. These plans are ongoing and should be reviewed at least annually to make sure that the treatment options are working and to adjust them if necessary. In many cases, when an individual has both ADHD and co-occurring conditions, the healthcare professional may elect to treat the ADHD first because primary treatment of ADHD may reduce stress, improve attentional resources, and may enhance the individual's ability to deal with the symptoms of the other condition. Treatment options for ADHD include behavior therapy, medication, skills training, counseling, and school supports and accommodations. These interventions can be tailored to the patient's and family's needs and help your child to control symptoms, cope with the disorder, improve overall psychological well-being, and manage social relationships. So that concludes my portion of the webinar. I'm going to hand it over to Dr. Arnold, who is Chad's resident expert, and he'll share information about prognosis and treatment. Thank you.
Hi, I'm Dr. Gene Arnold, Professor Emeritus of Psychiatry and Behavioral Health at Ohio State University, and Chad's resident expert. I've been doing research on ADHD for 50 years and was involved in the multimodal treatment study of children with ADHD, the MTA, in the late 90s, which has had a big influence on the treatment of ADHD over the years. Today we're talking about conditions that coexist with ADHD, or so-called comorbidity, and those have an effect on prognosis and on treatment. And more of the comorbid or coexisting problems have been arising during the COVID epidemic, but they're not new. There have always been some. And in fact, distinguishing ADHD from those complicating conditions has been a problem ever since ADHD was first recognized. ADHD is mainly an executive function deficit, difficulty organizing, paying attention, controlling impulses, getting resources together, planning your work and working your plan. And those are diagnostically cross-cutting. Many diagnoses have problems with executive function. In fact, for example, concentration difficulty is one of the 8 cardinal signs of depression. I like to think of ADHD as naked executive function deficit without all the trappings of mood disorder, anxiety, and other things that also have executive function deficit. This is the reason for the 5th criterion of ADHD according to the diagnostic manual. The others being the symptom count, that you have to have enough of the symptoms to qualify, impairment, prevalence in different settings, and the chronicity. The 5th one is the symptoms are not better explained by another disorder. However, you can have ADHD along with those other disorders, and generally ADHD would precede the others. It would come first, and it would continue if it's an episodic disorder like depression, which can come and go. It would exist in between episodes. Here's an example of the comorbidity in the MTA. Only 31% of that sample had ADHD alone. The MTA, again, is the multimodal treatment study of children with ADHD, children aged 7 to 9, who were recruited from 6 different sites across North America. About half had a disruptive behavior disorder, either oppositional defiant disorder or conduct disorder. 11% had tics, and 34% had anxiety, not counting simple phobias. So if they were afraid of heights or afraid of spiders, that didn't count. These were more serious anxiety disorders. 4% of that sample had mood disorders, but they were selected for not having major mood disorders. This is in 7 to 9-year-olds. And this percentage of co-occurring or coexisting disorders is typical for other samples also. But as the kids with ADHD, the 7 to 9 year olds, get older, there are other disorders that arise. For example, eating disorders. Because of the impulsiveness, there can be overeating, binge eating, obesity as a result of that. Substance use disorders for the same reason, impulsiveness, and also attempting to self-medicate to get some relief from some of the anxiety and other things that may be co-occurring. Tobacco has evidence showing that nicotine can have some benefit uh, on ADHD symptoms, but it's a deadly delivery system. It would be better to take prescription medication, which is purer and doesn't carry the risk of cancer and other things that tobacco does. Alcohol and tobacco both have some effect on dopamine, which is known to be involved in ADHD symptoms. Marijuana is claimed by some people with ADHD to be helpful to them, but it's probably because it's relieving the anxiety. They just don't care as much about the problems that they have. There's no good evidence that it really helps ADHD symptoms. There can be psychoses. There's a higher rate of schizophrenia, for example, and major mood disorders in people who start out with ADHD. Suicide is at a higher rate, and in fact, by and large, people with ADHD have about a 10-year shorter life expectancy. Suicide being one of the reasons, but other reasons being difficulty following the instructions of their internist and family practitioner about their health care. This slide shows what is typical for the whole sample of the MTA. Remember, that's 579 children aged 7 to 9. What was typical for the whole sample and for those who did not have anxiety. There were 4 randomized treatment arms in the MTA, one of them, the black line, being a community comparison group for which the study did not give any treatment, but they were free to seek treatment in the community. The green line represents an intensive multi-component behavioral treatment that lasted over a 14-month period without medication. The blue line represents intensive medication management without behavioral treatment, and the red line represents the combination of the two. As you can see, the 2 arms with medication, the combination arm, the red line, and the blue medication management line were significantly better. The response was significantly better than for those who had behavioral treatment alone or those who sought treatment in the community, 2/3 of whom got medication but not managed as carefully as in the MTA. Okay, so this is the way it was for the whole sample and for those without anxiety. Now, keep your eye on that green line and the blue line, the green line being behavioral treatment alone, the blue line medication alone, and watch what happens in those who have baseline anxiety. The green and blue lines move closer together and are now not significantly different from each other. The nominal superiority of the medication management continues, but it's not significant. And importantly, the behavioral treatment is now significantly better than the community comparison group. The difference between medication management alone and combination is still not significant. Another way of looking at the effect of comorbidity in the MTA sample is this one, in which the 3 active treatment arms are compared to the community comparison. And these are effect sizes. A higher score is better here. The community comparison group is 0 by definition. It's the thing to which the others are compared. Now, if you look at the black line, which is the 31% who had only ADHD with no co-occurring disorder, you can see that the behavioral treatment was not different from the community comparison, but medication, either with or without with being combination and without being med management, either with or without behavioral treatment, is effective compared to community comparison at about a medium effect size. Then the yellow line represents those with anxiety without disruptive behavior. And you can see there that any treatment works well with a large effect. And there's no advantage to the combination over the other treatments alone. The unimodal treatments, the medication alone or the behavioral treatment alone, were just as good as the combination. Then if you look at the green line, which is those with disruptive behavioral disorders, either oppositional defiant or conduct disorder, that green line represents shows that behavioral treatment alone was no more effective than community comparison, but medication, either with or without behavioral treatment, had a medium effect. Then the red line is the most interesting. This is the group with both anxiety and disruptive behavior disorder. And you can see there the combination comes into its own. There's a good response with a medium effect to either behavioral treatment or medication management, but when you combine them, you get an extra kick and a large effect. So one of the interesting things is that although ADHD with comorbid anxiety responded well to any treatment in childhood, you remember that yellow line, you can see had an excellent response, those with anxiety. That same anxiety predicts a greater persistence of ADHD symptoms into adulthood. Although comorbid anxiety, coexisting anxiety, helps the treatment response in childhood, it also predicts a greater persistence of ADHD symptoms later on. In fact, it's among the 3 top predictors of adult ADHD symptom persistence, and it supersedes things like IQ, socioeconomic status, and parent-child relationship. Now, looking at a different treatment, this is neurofeedback, electroencephalographic biofeedback, and looking at the responses here, these are differences between the neurofeedback and the placebo treatment, the sham neurofeedback. And the higher here shows more effect of neurofeedback, better response to neurofeedback. Those scores below 0 mean that the control group actually did better than neurofeedback. And what we see here, the 4 blocks on the left represent the change from baseline to the end of treatment. Anxiety actually got worse with neurofeedback than with control treatment, or stated more accurately, those who got the control treatment improved more than those who got the neurofeedback, significantly so. And the other 3 comorbid groups, those who had oppositional defiant disorder, those who had both, and those who had neither comorbidity, those who had no comorbidity at all, responded a little better to neurofeedback than the control treatment, but not significantly so. If we look at the 13-month follow-up over on the right, we can see that the group with oppositional defiant disorder without anxiety now responded significantly better to neurofeedback than to the control condition. And the group with anxiety tended to have a little bit of recovery. Those with neurofeedback did a little better in the follow-up than they did during the treatment. This is another way of looking at that. And here we're looking at effect size, the difference in improvement between neurofeedback and control. Above the horizontal dashed red line, from the end of treatment to the 13-month follow-up, those who got neurofeedback did better. Below that horizontal red dashed line is the anxiety group, which did better with control treatment than with neurofeedback. And you can see here that The red line representing oppositional defiant disorder improved significantly from end of treatment to the 13-month follow-up, showing a delayed effect. This is yet another way of looking at the same data in the neurofeedback study. The dashed lines represent the control condition, the solid lines represent the neurofeedback, and you can see that in general, the green lines representing those with neither comorbidity tended to do better. Lower score is better here. This is a drop from the baseline score to about 1.2, drop of 0.8, which is a big effect. And the dotted line for the green dotted line for the control group also did pretty well, but not as well as neurofeedback. If you look at the blue line, which represents oppositional defiant disorder, although there was some improvement in the control group at the end of treatment and 6-month follow-up, they deteriorated by the end of the 13-month follow-up. And the other two groups, those with both comorbidities or anxiety alone, tended to stay pretty flat. All right, that winds up the presentation. Thanks for your attention.